In Buenos Aires, the Portinos are incredibly hospitable. There's been a lot of data presented at this meeting using large series and things that are looked at in a very rigorous scientific method. I'm going to step back from that now because I think this is a syndrome or an etiology of an isolated, disconnected left pancreatic stump that many of us see clinically, but not very much is written about. The background of this is that the pancreatic duct is disrupted in up to 50% of patients following an episode of necrotizing pancreatitis. That has been shown in an ERCP study by Neoptomelos and al. In 1993. It's interesting to note that the anatomic neck and proximal body of the pancreas are uniquely vulnerable to ischemic damage, particularly from inflammatory changes with acute pancreatitis. Dr. Strasberg has looked at this a little bit, and the collateral circulation of the neck is of importance in this regard. A disconnected left pancreatic remnant is an isolated, viable portion of pancreas that has no connection to the ductal system or the GI tract. It has the capability of secreting up to 1 liter a day of pancreatic enzymes, which when activated are difficult to control and can cause much damage in the retroperitoneum. I became interested in this around 1993 when I was a young faculty member, and this is the curious case of R.W. He was an older, heavy male with infected necrosis and had an episode of biliary pancreatitis, which we treated by debridement, external drainage, cholecystectomy, and intraoperative cholangiography. In 1994, at an outside hospital, he underwent a distal pancreatectomy and splenectomy to treat his pancreatic fistula. And over the next 5 years at his outside facility, he had recurrent pancreatitis and recurrent pseudocysts, which occurred approximately every 2 years. These were treated by medical management, percutaneous drainage,